The next speaker will be Lotta Lundgren. Lotta is senior physician at the Department of Oncology, and Lotta has a long experience of treating patients with all different kinds of tumors. Please, Lotta.
Thank you very much for inviting me to this symposia, and I am happy to present some clinical data. I have to go back to my county hospital in the afternoon, so that's why we did this change. I have been a medical oncologist for more than 30 years, and I have met a lot of patients in different kind of cancer diseases. And I am happy to tell you that I have seen the patients more than one time. I have seen them several times, each patient. This is one of the first patients with metastatic melanoma that had a BRAF V600E mutation. And he got this vemurafenib, that is a BRAF inhibitor. And he could feel an effect already in 14 days. And he had a relief of symptoms. And as you see, this is all the tumors are black. And after 15 days on this PET scan, there was almost no active tumor left. But still, we cannot tell this patient the prognosis. We cannot promise him that he will be cured for the rest of his life. So that is a problem, and that's why we need a lot of research. I had the big opportunity to treat the first patient in Skåne with this tablet, and I was very happy to tell the patient, I know that you will have an effect of the treatment. I cannot always tell the patient this when I start a treatment. Today, in malignant melanoma, it is immunotherapy and the BRAF inhibitors that are the main treatments. And as we heard before, about 1/3 of the melanoma patients are cured, and that is mostly due to immunotherapy. And today, we don't have any prognostic markers or predicting markers for melanoma. So we are in an urgently need, because this is very expensive treatments, and you go on treatments for several years. So it's very important to have this research. This is the main factor that I think is important in the interaction between the patient and the doctor. And I hold them very, very high. And the highest is the continuity. I am able, in the county hospital in Helsingborg, where I am working, to see the same patient for every appointment. And that is very good, because I know the patient, I know the disease, and the patient feel very comfort with this. They also see the same nurse. So we are a team among every patient. I would like to present the case report for you. This is a patient that I met this week. And when he came, he was a healthy man, and he had blood in the stool. He was referred to the surgery department, and he was diagnosed with a rectal cancer. And then it's very important to know the stage, because then we can decide how to treat this patient. So you do a rectoscopy, you do CT scans, PET scans, and then you can decide the stage. And then in this patient, he had T3, a rather big tumor. It was probably spread to the lymph nodules, but it was not spread to other organs. And the tumor marker that we can measure today is called CEA, and that is a protein. And it's not that specific that Johan wanted to have, but it was normal. So we thought, yes, we can cure this man, and we had this multidisciplinary conference with surgeons, pathologists, radiologists, oncologic doctors like me, and we said the best for him is to have preoperative chemotherapy, and then we will do a resection. This is the different stage for colon cancer. In the beginning, it's only a small tumor inside the intestine, but as the time goes, it invades in the wall, and then it can spread to the surrounding lymph nodes and to other organs. So he was supposed to be in stage 3. If we look at the prognosis, we can see that there are different survival chances if you are in stage 1 or stage 4. And about 90% in stage 1 has a survival for more than 5 years, but only about 10% in stage 4. So it's a quite difference. And as we heard before, it's very important to detect this early as possible. And we know nowadays that we have different prognosis if it's a left-sided or a right-sided tumor. So the left-sided, and rectum is left-sided, have a much better prognosis. It depends on it. We found the tumor earlier. It's a lower stage, but also there is molecular changes in the right and left tumors. So after this chemoradiotherapy that the patient had, he was once again discussed in our conference, and he did an MRI, and we saw a decrease of the tumor. And then he went to rectum resection. And when we looked at the pathology report, we saw that it was about the same size, it was about the same stage. It had no lymph nodal metastasis, but it has one tumor deposit. And the CEA, the tumor marker, was normal. Then we know that the preoperative treatment, no, it didn't help that much, unfortunately. So what is the risk of recurrence for this patient? Then he is referred again to our oncology department, and we look at all the clinical prognostic factors that could say us that this patient has more risk of recurrence, and those are listed here. We have also algorithms that we can calculate and estimate, and the estimated risk for this patient was about 20% risk for recurrence. Then we know that if we give him chemotherapy, we can reduce this risk about 5 to 80%, so we cannot reduce the risk to 0. And that is why we want to meet the same patient for many appointments to talk about this. How are your risks, and how much do you gain for this? And I will say that every patient, they want treatment, despite all the side effects that you can have. So we suggested that he should have treatment with 5-FU. He had 5-FU already in the preoperative setting, but we thought that he could gain for this. He got this. He had a lot of side effects. He got 6 months treatment. And then when we stop the treatment, we meet the patient again, and we measure this clinical marker. And now the CAA was 2,000. It's a very big increase. He felt the same. He didn't felt, but he had elevated liver enzymes. So we did a CT scan, and unfortunately, we saw that he had a large volume of liver metastasis. What would we do? Yes, now we know that we can have an help of the mutation status. So we did an examination of the pathology sample and looked for KRAS, NRAS, and BRAF status. And fortunately, it was wild type. He had no mutation positive. We have a new conference again with our liver surgeons, and they said, yes, if you can decrease the tumors, we can do a resection in order to cure the patient. We know here we have in colorectal cancer, we have several different chemotherapy agents. We have biological agents like EGFR antibodies and angiogenetic antibodies, and also tyrosine kinase inhibitors. So we looked at all the clinical trials that are presented, and we saw that if we combined different kinds of chemotherapies together with this EGFR antibody that we could give because he was RAS wild type, then we had the biggest chance to good effect. So we took the decision together with the patient, but of course the patients never say no. If I say I suggest this treatment, then he says, yes, of course. You know the best. So he got this very heavy treatment, and we know that left-sided tumors have best response to this antibody. And we also know that there is a heterogeneity both in the tumor and among the metastases. We know also that we have different molecular subtypes, but we don't use that in the clinic today, but maybe in the future. But this is the CT scan. The left one is before treatment, and the right one is after 3 months of treatment. And he had a very good regression, fortunately. We also did MRI, another modality that you will hear more later, and it was also a very good regression. But he had a lot of side effects this time. He had skin toxicity, he had infections, very much tiredness, and so forth. But he was happy to get this message, yes. The tumor marker fell, and the X-rays showed a good regression. So he went to surgery. He did a hepatectomy, took away half the liver. He got more chemotherapy 3 months after. And this Monday, I saw this man, and he had done a new X-ray 9 months after the surgery, and we can see no evidence of disease, and the tumor markers is normal. So now, after 2 years of treatment with neoadjuvant, surgery, adjuvant, surgery, and adjuvant again, we can see that he has no disease in the body. I hope that I will see him several times and can leave the same message. The goal of palliative treatment, when you cannot cure, is very much harder. You must speak to the patient, you must look at the situation, and is there an aggressive tumor or not so aggressive? So you have to look very carefully for every patient. And that is my work. That is what I am doing every day. And when we talk about personalized medicine, we can look at the prognostic factors on the tumor, but also on the patient, and what other diseases, which age, and so forth. So we cannot treat all patients the same way. And we also like to have predictive markers that I can say, yes, I know that you will benefit from this treatment, or no, I know you will not benefit. So it also very, very important to see this. And still we have the same drugs to use, and we use them in different sequence, and in different intensity. We can give 2 drugs together, we can give one drug, or we can have intervals. So we have to try to speak and have an agreement of this treatment. And this is always you have to weigh what is the side effects, what is the patient situation, and what is its chance for responses and cure. And if we have more tools, like your research with genomics and proteomics, this will be very better both for the patient and doctors. And I look forward to the future and the future challenge to have new treatments and options for personalized medicine. So we can do this journey for the patient as good as possible. Thank you very much.
Thank you very much, Lotta. Please, you need a drink for lunch. And then all the way from California, Pacifica, which is close to San Francisco, we have Mary Tivadar, who will give a relative presentation. Please, Mary.
Okay.
To go up
Okay.
and go back and pointer.
Okay. This is my first time speaking about. I'm Mary, and I'm from San Francisco, and I'm here to talk about my husband who passed away in September from melanoma. He was being treated by UCSF for many months, and also was one of the leading first patient at San Diego with the best treatment. He was the ideal patient to beat cancer. He was an avid. He never let anything slow him down. He was diagnosed in September of 14 and had surgery to remove most of his lymph nodes that was already transferred to, they found some, so they removed them, and they think everything was okay. He got more treatment at UCSF, but the thing is the medications they were giving him, they were not eliminating the cancer, but it was slowing it down, but it wasn't taking it away. So every time we'd go, they would try a new medicine, new treatment. And the final one in San Diego was called the triple shot, where he would be infused with immunotherapy and then take medicine 3 times a day, very regularly, and was pretty much in the hospital being treated. He was probably seeing the doctor 3 times a week. So his melanoma was not from the surface skin. It was somewhere where the sun didn't see it. And actually, when he was diagnosed, the doctor didn't even know what it was. They were like, "Oh, it's just a bump. Well, since you're here, let's scan it." And that's when I got the phone call. I have cancer. So let's see how this goes. So this is why I'm here. I'm here for all the questions that we wanted to ask. We were like, why did he get it? Why? He's a healthy, active surfer. He competed at AWTs. He was surfing daily, snowboarding, skiing. Nothing slowed him down. I mean, this person was active. So shout out to everybody who's here with the interest and motivation to push through the uncertainty for a better future. You're fighting a battle for those who are also fighting. Be brave. So when they say fight cancer, it's funny because they're always like, you're going to beat it. Well, of course we all want to beat it, but the hardest thing nobody tells you is how to be brave. So, let me see. I'm new at this stuff. So the diagnosis, the uncertainty, the resolution, the hope, the struggles, the stability, and management. So the diagnosis is the first thing that we were hit with. And then the uncertainty, well, we're in one of the best hospitals that, and they're like, we'll take him. He's strong, healthy. He'll be the ideal patient to beat cancer. He'll be our star person. So we had a lot of hope. But then we had to struggle with constantly being told, well, this one didn't work. This one didn't work. But it's not growing, but it didn't work. So we managed it. Our life went from active, because we're both self-employed, and he stayed home dealing with the after effects of medication. Even though he was willing to do everything he could, the medication does have a side effect that he was willing to take, but I had to help. So I'm not very good at this. So he called me, and that's where we're talking about the phone call nobody wants to get. And then one test after another, and then cancer put your life as a hostage. For many years, we were a hostage to the what ifs and the whys, and will there be a diagnosis, or will he be the one to make it? Obviously, he lost his life in September this year, the day before his 53rd birthday. So we didn't get his birthday party. So he was a surfer, windsurfer. His life, he knew his whole life was going to be different, but he was willing to take the risk. The fatigue, the keeping it from everybody too was difficult, because he was very, very proud. So he would never let anybody know he had anything. So he stayed home a lot, where he was always running around, surfing, and all of a sudden nobody saw him anymore. And they're like, what's wrong with him? Oh, he's tired. But eventually people found out. So this was something that different in California, where you guys have a different health care. We are on a health care where basically you pay a percentage, and if you can't pay that percentage, he became a study. Because you can stay with that, but it gets so expensive each treatment, you might as well buy a car each treatment. So the thing is, with your insurance, was always asking, will our insurance cover this? Will our insurance cover that? Will our insurance cover this drug? And that was always the hole in the weight, where you guys don't have to do that. You just get your treatment and everything's good to go. Well, many people in America have to wait for approval for a drug, for a test, for basically everything. And sometimes you're denied, and sometimes you're not. And then you're managing your personal finances in everyday life. So people forget that part of cancer. Your whole life is on hold while somebody's recovering or sick. You're the one that's holding the fort up. You're the one who has the children, who keep everything. Dad's okay. He's just sick. But he'll get better. He's with the best doctors, and he was with San Diego. He was the first patient with this new triple drug. And I don't know if Gorgie's our family, and so he invited us to share this story, which I wasn't very happy with sharing, because I don't like to talk about it. But since I came all the way from San Francisco, I thought I would share it, because this is the side you guys don't see, the side that affects, and it never goes away. So, and managing the personal finances in everyday life. So he was an artist, the studio. I helped run the business when he was sick, and I've been doing it forever, so I'm still running it. And then, oops, I can't get this right. So there's the things where the resolution is. We had to find the best doctor. The first stage was the surgery, removing the lymph nodes. The radiation, we did everything. The chemotherapy, nothing was taking it away. The drug therapies, he was on unit therapies, which he lasted for a few years with it, but at the end, we were skiing July 4th in Squaw Valley. It was still snow on the top, and he was sick, but he was like, I'm skiing with my family. I'm doing it. Nobody could believe he was going to go skiing. He's weaker than he used to be, not as strong, but nothing put this guy down. I can't even believe he went. So he went skiing. That was on July 4th. September 28th, we walked through Alcatraz with his mother, and his mother knew something was wrong. He was a lot thinner, weaker, he wasn't walking. We eventually told her that he had cancer, and nobody knew. We kept it a secret even from everyone. So by by the beginning of September, he was admitted to the hospital with it metastasized. The tumors started going in his stomach. They were draining it. What do you call it? Water, trying to create comfort where he was getting bloated around. It just went everywhere. It spread to the point where it was removing from the back of his head they moved it from the side of his head because it was infringing on his vision. And I think once they did the surgery, it seemed like it just was fire. It just blew up. It just went fast. And by a week later, they left him in the hospital. They basically gave us the diagnosis. There was nothing they could do anymore but take him home. And I asked him, do you want to stay in the hospital or do you want to go home? I prefer the hospital because I'm not a patient. I'm not a doctor. And it's not great to see somebody sick next to you. And my daughter helped with the medication that they basically leave at your side and go, if this is his problem, you can fix it. You're like, I'm not a doctor. But we did it. And within 5 days of being in a hospice, he passed away in front of all of us with his last breath. He couldn't walk anymore. It went so fast at the end. It was like seeing a different person. So let's see. So this is where I'm at. I mean, there's no, people always ask you, how do you handle it now? You don't, you really don't, but you can hide it. And so the bottom line is why I'm here is our life is over. That was his last photo, by the way. That's us in Skåne. You can tell he was thin, but he wasn't going to slow down. He wore a hat, and he was like, oh, okay, no one's going to see my tumor on the side of my head. So basically, you don't stop ever. And hopefully from this place, we can find a solution so nobody else has to do what I still have to deal with for the rest of my life. Cancer took away my future, took away my life I knew, and it took away my best husband, my husband, for 23 years. So he was the first one I was with, married, had kids, so this is all new for me, this second chapter of my life. I'm not good at this moving forward, like they say, but I have a great family that's all supportive, and I'm glad I was invited here, even though I was kind of reserved. Like, I don't really share my personal stories with anyone. Nobody actually knows. You guys actually probably know more about my personal story than most of my friends because I shy away from discussing cancer. But the weird thing is because I've advertised this on my Facebook wall, I have people kind of sending me private message like, you know, my husband has melanoma. I'm like, I didn't know. Because he's kind of like doesn't want to share it. I'm getting people connecting, trying to reach out to me and asking me how I'm dealing with it. And I wish I had better advice and telling them, you know, fight. I don't know. But I'd like, instead of saying fight cancer, the new thing people say, I see that on the cars, like fuck cancer. I'm like, well, how about be brave? Because there's nothing else you have to, that's the only thing. You're brave when you sit there, when you get the diagnosis. You're brave when they like, this medication's gonna hurt you, but you'll get healed. And you have to be brave because your family and your kids rely on you. So there's nothing else. So the whys are, why are we here? We're here to find answers. And hopefully nobody, I know they say you're going to, but hopefully nobody has to go through life alone, missing someone. Okay? So there I am with my life story, and thank you for inviting me. This is not my specialty. If you want art, I can help you with there. So what's the best thing I can say is I am managing after a diagnosis, not with everybody, and I feel like you guys are the answer to everybody's why. I hate that question, is why. But we're all here for that. Thank you. I don't know. Thank you.
Thank you so much, Mary. This was really something. The next speaker is Agnes. Agnes Kozma from Budapest, who will give a patient presentation. Please, Agnes.
Which one I'm pushing now?
For go up in the next slide and go back.
Okay, thank you. Good morning, everyone. My name is Agnes Kozma from Budapest, Hungary, and I'm happy to be here. And actually, I'm happy to see all these presentations and thoughts about on science and experiences on patients and relative side. And when I was putting together my presentation, since then I have a lot of thoughts in my head, and I might be a little bit different than my slides. Actually, I put a lot of facts. I was diagnosed with breast cancer in 2013 when I was 45 years old. I got a first call for a mammography, and they find out that I have a tumor in my right breast. And this was the picture. Actually, I had it like I felt lost. I didn't know what's going on, and I'm sorry. It's my whole life is really changed. Actually, what has happened, the fact is that in February there was the mammography, they took a core biopsy, there was a PET CT, and actually 5 or 6 months later I got the first surgery when I had a mastectomy, and I removed my right breast. And I got chemotherapy, a combined chemotherapy, which I got an allergic shock. I couldn't follow on the chemotherapy, and this is how I look like, my whole body. I don't know if you can see the picture. Nobody's seen it ever after this chemotherapy, and I had a choice of going on with the chemotherapy, because actually the oncologist didn't want to give me anything else, or stop the whole thing. So I decided to stop the chemotherapy and all the therapy, and I tried to go on complementary treatments. I tried several things. I spent a hell of a lot of money. And actually, I was quite okay for 2 to 3 years. And then, on 2016, the breast cancer came back. First of all, they didn't know what happened. I diagnosed with a very serious anemia, and just after a couple of months, they took a core biopsy on my bone marrow, and they found out that I had a metastatic breast cancer. And then later on, it was also in my uterus, and they told me that, look, we didn't really lie to you, but you don't really have a chance. So I was there with the Mission Impossible, and what I did at that time is I didn't go on any complementary treatments. I have a very, very, very good friend who is sitting here with us today, who helped me to see the diagnosis a little bit closer, so I get a sort of a personalized diagnosis. And with the collaboration with the oncologist, I got a targeted treatment. And after the third chemotherapy and targeted therapy, my blood became normal. And I got 6 series of chemotherapy, just only with docetaxel, and the targeted therapy, the Herceptin. And I can say today that I'm cured. There is no sign of cancer in my body. But it was very difficult for me, for my family. I have a 12-year-old daughter, and I'm raising her alone. And we both had to deal with the fact that what happens if I don't survive the therapies? What happens if it doesn't work? So I just wanted to share a little bit it's not really side effects, it's what did I felt. It's like in the 2013 and 2015 period, the psychological shock, the shame, which, thank you for Mary, but this is true. It's like when you have cancer, you shame that you have cancer. You don't share with the whole. I mean, maybe everybody's different, but it's very difficult because you feel a sort of a rejection that wow, she has something. The boogeyman is there. It's like, wow, we don't want to go closer, and you have to cope with the changes. You have to cope with the changes in the parents, especially in the breast cancer. You have to cope with the changes of all the parents that after the therapies and the treatments, and it's you just have to deal with the fact that your life is not the same as before, and your surrounding has to deal with the same thing: your family, your friends, and. This is actually basically just a therapy, but what is the most important is that what I had to difficult to cope with, and this is what I wanted to share with you, is that it's very good that we have science today to help us. I think so. I am part of all the cancer patients. We are very grateful for science and all the physicians and everybody who try to find a cure for cancer. I don't like the word of fighting, because in my word, the fighting is like shooting all over. There, if we find something, we find something. If not, we don't. So, and I think so that we have to somehow, us patients. In my other side, like an economist, I can also help, and also the physicians, all the other therapists, and all the researcher, is that to combine somehow together that information that we have, share, and try to find the best out of it. Because what my experience is that the whole thing is like the treatments are centralized, very rigid. The pathologist goes after protocols and experiences. And even that we are talking about personalized medicine today, I don't see personalized medicine everywhere. And it's not patient-centered. It's like, I'm sorry to say this, but maybe it's coming from my profession. Your profession is to cure the people, and you help us. And mine is like how to make business development strategies. And it's like a little bit like different, like everybody has a different interest. A patient interest is to be cured, to be okay. The scientist interest is to find a solution for a problem. And if we put together maybe the whole thing, and the doctor again is like find the treatments. But the treatments are not always the cure. So I just wanted to talk about and share my experiences in order to help you to also to go in a little bit different direction, to see that maybe all together we can win this battle, if we want to call it a battle or a fight, but and to be more open and positive. And I think so it's a very, very good opportunity, this Cancer Moonshot, and to have the opportunity to share experiences worldwide and get involved almost everybody who is in this, because not only doctors and physicians, but also we are patients, and we have a different interest and goal that you have, and maybe we should just put together. And this is what I see from my experience. It would be the best to make to improve progress, to have a personalized treatment, which means a personalized diagnosis, treatment, and rehabilitation to save lives and enhance the quality of life of the cancer patients. And another thing that I missed is the communication. Because the communication today on cancer is either commercial, either too scientific. And if you go on the internet, people are sharing their worst experiences, so everybody's frightened. And that's what I just put, sorry to be a little bit the boogeyman, but this is it. Today, cancer is the boogeyman. It's like, if somebody has a cancer, is wow. either he has the worst scenario, he is the hero because he survived something. It just, maybe we just have to take out these frightened pictures. I know it's hard. I've been through. I'm here today. I'm sharing experiences, and I'm willing to dedicate my life and help to help more cancer patients. And I'm open to any questions if you have. And thank you for your attention, and I'm hoping to get a better future.
Thank you so much, Agnes. The next speaker is Professor Håkan Olsson, who comes from the Department of Oncology. Håkan has been a professor of oncology for many years and dedicated all of your career to oncology research, I guess.
Yes.
Please.
Thank you. How do I move this forward? I'd like to start thanking the organizers for inviting me, and they gave me a very big title, The Big Picture Within Cancer Diseases. I will try to give some personal views around it, but it's I think the title doesn't actually, it's impossible to fulfill it actually. If we look at the cancer diseases, they have been with us all back to the dinosaurs and all as long as there have been organisms and animals on the earth. And what is the big difference between different time periods is where in the body the tumors appear. The environment governs that, but the genetic disposition is there behind it. I know Johan already has shown these figures about the most common cancer diseases and the incidence and so on, but I'd like to point out that we have a very peculiar picture for man. 1/3 of all tumors in females are in the breast, and 1/3 of the tumors in the males are in prostate. No other animal can match that. So should we do research and come further on, we need to do it in humans. It's my personal belief, with a little help of the animals, of course, but we need to do it in humans. The most common tumor diseases, if we group them together, are the skin, actually. But as we heard, many of the skin cancers have very good prognosis, and it's mainly melanoma, which is some squamous carcinomas who kills us. The incidence, as Johan pointed out, is increasing, but the mortality is stable or decreasing a little. And I will show you some provoking figures here, unfortunately in Swedish, but it's breast cancer, melanoma, prostate cancer, and colorectal cancer. And I show the same picture, a massive increase in incidence, but mortality is just the same. And how should we interpret that? I think that we have a massive overdiagnosis of cancer. The small tumors, we are not able to tell if they are dangerous or not. So this is a real challenge for genomics and proteomics to try to find out in the small tumors who are the really bad ones. And maybe later on we should not actually diagnose so many with cancer as we're doing now. And I think this is partly due to the pathologists who like to be on the safe side and saying, oh, that's probably invasive cancer if you have a very, very small tumor. And you see, this begins long, long before we have effective therapy for the tumors. So it's not, you cannot say that this is due to therapy. Some part of it may be later on here now, but it started long before we had effective therapy. And 1912 in Sweden, the most common tumor disease was stomach cancer. Now it's not on the top 10 list. It's breast and prostate and some others. So what we will see in the future, we will see a different cancer panorama depending on the exposures we have. It might not later be breast and prostate, it might be other tumors, and we're always a step behind to understand what are causing the tumors. We do screen to try to find tumors earlier. We have the breast cancer screening starting at age 40. We have cervical cancer screening, and we have started in Stockholm to have colorectal cancer screening, and some are advocating that we should also have prostate cancer screening. Now it's opportunistic. If a man has a symptom or comes to for another healthcare problem, PSA is taken. We do have risk population, women with on the mammograms who have a high breast density. The HPV carriers probably will be the group which we should screen for cervical cancer only. And it's turning around now to be the case, and we're also vaccinating young women, you know, against HPV. We screen mutation carriers for the strong cancer genes, BRCA genes, melanoma genes, colorectal cancer gene, for instance. And in the United States, they started to screen heavy smokers, the one who smoke more than 25 cigarettes a day, with CT of the lung, and they've shown a better prognosis to do that. And it's discussed if this is something we should do in Sweden also. Now, I apologize for some of the pictures have Swedish said, but I will try to. This was done 1984, an estimate in Sweden by the Swedish Cancer Committee to try to estimate why do we get cancer. And it was the same time as Doll and P2 in England did the same thing. And as you can see here, most of the cancer cases are ascribed to the diet, but all from 10 to 80%. It's a very uncertain estimate. Tobacco use account for 1/5 of all cancer or 1/3 of all cancer deaths. And reproductive hormonal factors, that is how the women get children, and hormonal factors, hormones given to women, account for the third big group. But you see, the big things which people think they get cancer of, air pollution, ionizing irradiation and so forth, have a very little tiny part of the cancer panorama. And UV light maybe have 5–10%, but not more. And of course, recently we have also seen that hereditary factors is important. Around every 10th patient coming to our clinic have a strong family history compatible with a dominant inheritance. But even more, around 20–25% more, have strong genetic factors which are not dominant. They could be recessive genes or genes working together with environmental factors and so forth. And it could be that almost half of the cancer panorama have strong genetic, because sometimes we had the wrong father, we have small families, and we have moved from in between different cultures, don't know the family history actually. And of course, the cancer, both the predisposition genes and the somatic genes in cancer have very much been helped by the characterization of the human genome. We now know that almost 98% of the protein coding regions, but the big challenge for us is the non-coding regions, the one where we have enhancers and promoters and so forth. And most of the predisposing genes which we find now are in the non-coding regions, not directly making proteins. And that makes a great challenge for us to understand, and also understand the functional understanding of these loci. And also genes are more complex than we thought before. They could be spliced, and different parts could be transcribed and so forth. So a genetic part could actually give rise to a number of different products. And if we go to the predisposition genes, we have a large problem here also, because what we know just in the beginning are the strong genes, who are uncommon in the population, but give high risks as it is. Then now also we know about middle stronger genes and the polymorphic very low penetrant genes, but who are common in the population. And most of the genes now which we find some predisposing for cancer is in this sector just now. And if you look at this, is the picture with melanoma. I've been very much involved in large international consortia trying to find genes there. And what we know then in the beginning is the CDKN2A gene who gives rise to melanoma and pancreatic cancer, the CDK4 and the BAP gene, which is a eye melanoma gene, for instance. We recently characterized the MITF gene together with a French cancer group, and then we have a number of low penetrant but common genes in the population. So I think we now have 30 genes for melanoma predisposing. And this is a great challenge to understand and how we should give counseling and advice about these. It's easier to act on the strong ones who are not so common. So the picture on predisposing genes are rather complex. A couple of months ago, we had around 182 loci or genes for breast cancer. The last days, we are now up in 202 genes in breast cancer predisposing. And for melanoma, 20 loci and 30 loci for ovarian cancer. And it will be a great challenge to use and understand the function of all these. Now, when we look at health consequences of exposures, this is the UV light exposure, the positive things, with especially the D vitamin thing, and the negative factors, which are skin cancer. If we balance this in cohorts, the astonishing thing appears that people who sunbathe or who are out in the sun live longer than people who avoid the sun. So that means that this part is more positive for humans than this negative part. So how should we advise on this in this complex situation when we take all diseases and all health conditions into account? A great challenge. The hormonal carcinogenesis in women is also very peculiar. If you go in the 18th century, women had 6 to 8 children. 2 of them died early. They had a later menarche, but the same menopause. And the modern woman has 1 or 2 children now, nurse them for a very short time and have them late in life on an early menarche. And also using, 80% are using oral contraceptives before the first child, and previously 40–50% used hormones for menopause. Now it's around 20%. This picture, the modern picture for the modern woman, is predisposing for gynecologic cancer. And it's the strongest factor, the menstrual cycles here and the hormonal stimulation of the breast and the gyn part. But of course we can't tell women you should be pregnant all the time, which should be the natural things. So we need to develop new oral contraceptives, new hormones, or new ways of mimicking pregnancies to avoid cancer in women. But we're not there now. So again, if we take the contraceptive pill, we have a number of, positive factors here, as you can see. We recently have seen a number of soft tissue sarcoma, colorectal cancer, endometrial cancer, ovarian cancer, who are protected by using the pill. While breast cancer, there is a slight increase in the incidence. But again, I think we probably will come out that using the oral contraceptive is positive overall for women. We don't have the data yet, but much of this point to that direction. How can we now sort this all out? We can use large cohorts, and we do have them here in the Southern Healthcare region. This cohort of 30,000 women who were healthy in 1990, we are following now forwards in time to try to sort out this balance, what is positive and negative with different exposures, to be able to advise the population in a better way about health and disease. We have many examples where prevention is successful. Lung cancer, smoking, the hereditary breast cancers and prophylactic operation, colon cancer screening, breast cancer use of peri- and postmenstrual hormone substitution. When we reduce that, we reduce the breast cancer incidence. And ovarian cancer is, to a large degree, protected by using oral contraceptives. Now, turning into tumor biology, we have a number of challenges in the future here. Late diagnosis versus early diagnosis, as I pointed out, local versus metastatic disease, the tumor heterogeneity, the tumor type and tumor locations, the number of genetic aberrations, oncogenes and suppressor genes, drivers and passengers, growth fraction and proliferation, angiogenesis in the tumor, and now the great thing is immunity. Every speech on the ASCO and IRC meeting in the United States now have a part at least about immunity. And what is very interesting, the diseases which I thought was the worst one to treat, with the most genetic aberrations, that was a metastatic melanoma and lung cancer, they have the largest amount of mutations. And the mutations give rise to antigens which you can attack with the immune apparatus. So suddenly we have therapy for the worst tumors. And that is, for me, very surprising, I would say. And we also know that each tumor, even this is pancreatic cancer, they have only a few drivers who really is important to find to attack with therapy. 5, 6 mutations are driving pancreatic cancer. And if we knew them in each individual, we would have a personalized medicine in pancreatic cancer. But so far, we don't have all that information. Another thing, I apologize, there are dark, some of the pictures here, but is the evolution of tumors. We, in melanoma, but this is lung cancer, but we've done the same in melanoma, we can actually see which are the early mutations in the tumor and which are the later ones in the metastatic unbranching situation. And it looks like, I'm just saying it looks like, we don't have the information yet, that it's important to guide the therapy against these early changes and not so important the later changes. But we need to take serial samples in the metastatic situation and so forth to more and better understand this. But this will completely change, I think, cancer therapy when we know more about this. We know also how many genetic aberrations are in a tumor, as I said. Here's a breast cancer with few aberrations, and another one who's full with genetic aberration. The prognosis is, of course, worse in this situation. And we can do gene expression analysis in the same way to get important information, but we still don't know how to use the gene expression in the clinical setting as it is. We talked about the immune system, which seems to be very important, and we are starting to get the number of the lymphocytes is important, the type of lymphocyte is important. If they're myeloid-derived suppressor cells, it's important. Number of mutations in the tumor is important, and some tumor types are better to treat than others. Understanding the PD-L1 could also be important, and the HLA system. But we need more markers, and I hope the proteomic area will give us these markers later on to better guide the therapy. Now, if we look at the evolution of therapies, this was some years ago when the targeted therapy came up. It will put up here growth factor and signaling therapy, chemoprevention, gene therapy. And immune therapy didn't have previously, except for interference and some other therapies, any great impact. Cytostatic came after the war, hormonal therapy, a little before radiation therapy, and surgery in the 19th century was the first one. But what has happened is this, that the immune therapy has taken over almost everything we do in oncology now. And there is a disappointment about the growth factor and signaling therapy. They increase progression-free survival, but there are very little signs yet that they could cure the patients. But maybe by combining treatment modalities here, we can take things forward. But it is astonishing, the re-emergence of immune therapy, I would say. Now, when we target therapy to the cell, there seems to be a better way and a better results if we can treat the cell surface, the membranes, the receptors. The further into the cell we come, the more side effects, the more common final pathways, which doesn't give the same good results as these up here. And where we now are fortunate to have rather good therapy with targeted therapy is in breast cancer. We heard two new things with breast cancer, melanoma and immune therapy, and lymphoma and the CD20. There we can actually say that maybe we have cures for some of the patient diseases. Now, Hanahan and Weinberg's hallmarks of cancer has been a very good background picture to have when we have it. But I would like to point out that we actually have therapy for all of these hallmarks. So the problem for us is how should we combine this, and which hallmarks in each patient is working. If we could combine it the correct way, maybe my negative attitude against targeted therapy could be different. And here is a picture of breast cancer. And as you can see, all these signaling ways, we also have effective therapy. So for the breast cancer doctors, now it is a thing how to combine it and when to give it in the course of the disease. Should it be given even adjuvant and not only when the patient has a recurrence? And this is also a challenge. The metastatic, the survival here, the poor survival in the metastatic situation compared with the primary tumor. So our goal must be to try to define better therapies to prevent metastasis and to treat metastasis. We are already rather good for the primary tumor. And this is the survival figures for childhood cancer. Extremely, look at this. What has happened since the 50s and 60s and now. Most children, well, the overwhelming number of children are cured, but with long side effects which can appear 20, 30 years later. New tumors, cardiovascular diseases, and so forth, but still astonishing figures. These are the data from US against children and adults on the survival. There is actually a decrease in improved overall cancer survival, both in England and United States, which we not see the same thing in Sweden. And in children, you see it also. And I would like to end with this picture. What will happen in the future? Well, this is from Boston, the MIT area, where the hospital, the research areas, and private companies are joined together on the grounds here. And now Google and some other of these big, Facebook and many others, are moving in to handle big data together with this cluster. We are approaching this in Lund also, and the Ideon thing, and the biomedical center here, and the hospital. So I think for the future, this will be the thing, the convergence of these things, trying to sort it out together, multidisciplinary, not only medical people, but also technical people and other together. Thank you very much.
Thank you very much, Håkan. Now, in the interest of time, I think we have to move on with the next speaker, who is Dr. Goutham Edula. Where is he? He's here. Goutham is a radiologist by training, and he has worked both as a physician in the radiology department, but also for Astra here in Lund, and now he works in the crossroads between industry and the healthcare, and as an entrepreneur. Please, Goutham.
While we try to get my slides on, I can start with my presentation is in three parts. One is as a relative, and then as a physician, and then as a technologist. So I'll start with the relative bit because I don't need the slides for that. So when I was a teenager, many years back, like 20 plus years back, my dad came one day. He was a leading ophthalmologist at the time. He said that I've been diagnosed with colon cancer. I was already in the medical school, so I knew what cancer was, but I was not fully educated on what it actually means. I knew what it was, but I didn't know what it actually translates to. So it was a Christmas way back, and then it took exactly 364 days for him to disappear from my life. What it started was when he told me that he had cancer, he said that it is like any other disease. It was like heart disease or lung disease, so it was another disease. But we found three differences as a family, that it was very quick. Unlike any other disease, cancer would take your life and your family's life and hope and everything very quickly. And the second thing was the fear. Whether you survive with cancer or you die with it, it gives you fear. And the third worst part was the chemotherapy. It's the only treatment that makes the patients feel more worse than they actually are. After going through this, I realized that when it comes to cancer, it is not really about curing it completely. It is about informing about it clearly. That is more important rather than trying to cure it completely or whatever. So the second part of my presentation is going to be about the radiology bits. And finally, I'll end with a bit of technology. This presentation was mainly made for patients because I spend a lot of my time in India now working in the radiology departments in the hospitals, so I try to make it more patient-centric. In Sweden, I run a company called Biomedical Imaging AB, which does image analysis and analytics for Swedish government and companies here. This is a very basic presentation. I see imaging as a radar in our war or battle or fight or whatever it is against cancer. What does the radar do? It picks signals. And the problem with imaging as a radar is it picks sometimes wrong signals or false positives. So there are different modalities. For the sake of audience, if there are anybody who is not comfortable with English, so I just had some Swedish translations in the bottom. There are broadly 5 different types of modalities or ways of imaging. One of them is pretty old ones, the X-rays and computed tomographics, which use ionizing radiation. They measure tissue density, so you're measuring structure. Second popular type is magnetic resonance imaging, where you are looking for excess of magnetic spins of protons in a field. And third one is a positron emission tomography, where you give a radio tracer and you're trying to measure the signal back. And there are other 2 modalities like ultrasound and optical imaging. So what does it mean for a patient with cancer is when you are diagnosed with cancer, you are probably getting all of this in varying forms. And each one is more stressful than the previous one. So whenever we report on patients with cancer, it is always the doctor is stressed, he wants to give the right diagnosis, and the patient is stressed because they don't want to know a further bad news. So why do we use imaging? So there are a lot of reasons why it is done, and most of my professional work has been around screening. So can we detect cancer years before it actually shows up? And that work has been done in different areas, like for lung cancer or for breast cancer, colon cancer. Imaging for screening is one of the big areas that has been where it is used as a tool. So as I said, CT screening for lung cancer and even for mammography or virtual colonoscopy for colon cancer for those who don't want to have a colonoscopy on a regular basis. The other popular area is diagnosis and staging. So where we are talking about what is the extent of the disease, is there involvement of lymph nodes, etc. This could also mean involvement of vasculature and extent of lymph node involvement, etc. Imaging is also used for treatment planning, where you're trying to figure out what is the best treatment option for this particular type of cancer. Or for planning for surgery, if you're trying to do a surgery, what is the extent and location of the tumor. And treatment response imaging is used in a number of oncology clinical trials where you're looking at changes in volume or you're looking at changes in sort of function, where you're making a PET imaging, trying to see how the tumor is behaving. disease progression in cancer, radiotherapy, and also for long-term follow-up. So the list of things that imaging is used quite a lot. That means for a patient with cancer, imaging is, in terms of clinical, it is one of the biggest sort of diagnostic procedure which is done. Okay, when it is done, this depends on the type of cancer and what we're trying to see. So I'm just taking an example of lung nodules. There are a lot of screening studies for smokers where they're trying to see if low-dose CT can be used for detecting cancer before it becomes obvious. For example, if they don't have any nodules on a low-dose CT, they would not get one until next 12 months. If they have smaller nodules, they would get a repeat in 12 months. If the nodules are bigger, it would be done between 3 to 6 months. But if they have nodules which are quite big, which needs immediate follow-up, maybe there is a PET or a biopsy or CT with contrast that is going to be done. So one of the challenges with medical imaging is radiation risk. Of course, when you're using ionizing radiation with CT and you're doing it a number of times, there is a risk of inducing radiation-induced cancer. The other problem is emerging guidelines. If you look at the number of guidelines that you could follow for diagnosing or classifying patients with cancer, there are n number of them. Maybe not a big problem in the Western world, but when you look at the developing world, infrastructure access to CT scanners, access to MRIs, PET scanners is very limited in most of the parts of the world. And getting oncology-trained radiologists is another big bottleneck because it's a very specialized field. And a lot of speakers have talked about immune therapy. So what is happening with patients with immune therapy is that the response is quite varied, and it is over a long period of time. That means we have to image the patients for a number of months to actually see what is happening with the treatment and what is the response to treatment. So I'll just switch to the informatics side of things, or the technology part of it. So people have talked about proteomics and genomics. An emerging trend in radiology is what is called radiomics. So the idea is that when you make a series of radiological investigations for a patient, you are producing a signature. And that signature is unique for that patient or that group of patients. So if you take prostate cancer as an example, we can measure the diffusion, perfusion, and also anatomy using different modalities. And these images can then be used to pick out the structures, different parts of prostate, and what is the activity in each part of it. And using that data, we can then do change measurements in texture, intensity, and also on the wavelets. So that means you basically produce a three-dimensional map of this series of images that have been done. Now, this, in theory, can be correlated to all different other omics. But unfortunately, nobody has shown successfully that this is possible because each individual omics is very specialized, and the signal it gives may directly not translate to what you see on an image. Much of the positive data is around proteomics because the protein signature is pretty close to what you see on imaging as a structure. So finally, the idea is that this would help in coming up with some kind of a prognostic or diagnostic information. So this data is now, radiomics as a data has been developed in lung cancer and prostate cancer, maybe not much in melanoma. This is sort of an emerging field. The other example is how do you differentiate between a benign tumor versus a tumor which is probably going to be more aggressive? So this is just an example of a benign tumor on CT and an adenocarcinoma. If you look at them as a radiologist, they probably look the same. But if you take, say, their Harlick entropy, which basically measures the sort of the difference or the heterogeneity in the image, that is much higher. The red indicates much higher entropy, and the shape. So granulomas have more uniform shape compared to a malignant tumor. So this is a non-invasive information. You're not doing a biopsy. You're just picking up from the image so that you can differentiate between granuloma, which is fairly benign, versus an aggressive adenocarcinoma. So with all this, what is happening professionally is I'm sort of replacing my own profession. Like radiologists are slowly going out of relevance if you try to build the signatures. Because we can't, with human eyes, see all this information. So it has to be computers that churn out this information and build these signatures. So today, for a typical whole body CT, it takes around 2 days to produce the radiology signature for different parts of the image. And humanly, it is not possible. I mean, no radiologist can build such a signature. And we hope this information will be useful to classify these patients and maybe treat them better. Okay, that's my short talk.